I'm Dallas Gay, co-chairman of Think About It, the drug abuse program sponsored by the Medical Association of Georgia Foundation. I want to welcome you to Project DAN, which stands for Deaths Avoided with Naloxone. But before we get into the training, I want to share a personal story with you to help you understand how important this training can be. This is my grandson, Jeffrey. Jeffrey had his first opiate painkillers when he had his wisdom teeth out in high school, and he instantly liked the effect. Perhaps there was a genetic disposition. He continued to source out those pills wherever he could find them, including my medicine cabinet. Our family and his teachers and his coaches and friends all tried to help Jeffrey, but what we did not understand is that he had already crossed that line from bad behavior of drug abuse into addiction. And addiction is a chemical neurological change that takes place in the brain that seldom, if ever, returns to normal. So Jeffrey struggled through high school and through his freshman year in college. When he could no longer deal with that addiction, he checked himself into a rehab center and stayed there about 6 months. When he came home, drug-free, he lived with his parents, had a full-time job, and a new drug-free life. After about 2 years, he re-entered college, and life seemed like it had never been better for Jeffrey. But then one night, he went out with an old friend that he had done drugs with before, and that addiction was still with him, and he had opiates that night. And since he had been drug-free for 2 years, his tolerance to those opiates had gone down, and the effect was dramatic. The young man with him took him home that night, helped him walk upstairs to his bedroom, let him lie down in his own bed, and stayed with him till he could not get him awake. He then went downstairs and woke up Jeffrey's father, who rushed upstairs, and when he saw what was happening, he immediately called 911. When he did that, the boy with Jeffrey fled the house. He did not want to see the police or risk being arrested. But this was 2012, and in 2014, we passed the Georgia 911 Medical Amnesty Naloxone Law, which would have provided amnesty to that young man if he had simply picked up the phone and called 911 to save his friend. But that didn't happen that night. The second thing that didn't happen, there was no naloxone in that house. That's the antidote for opioid overdose. There was none in the house, and furthermore, the police who were the first to arrive on the scene did not have naloxone. The new 911 amnesty law allows anyone to get prescription for naloxone who might be close to someone in overdose. But that didn't happen either. And third, probably the police and the father were not well trained in certain overdose first aid maneuvers that can extend that life till help arrives. 3 things that could have saved a life: call 911, use naloxone, use first aid. Those weren't available to Jeffrey that night, and he did not survive, 21 years old. So you're going to be trained to save a life, and when you do, it'll be a good feeling for you, and the person you save is going to be very grateful. But I want to tell you personally that that person's family, that person's loved ones around him are going to be eternally grateful for what you do. And now I want to introduce you to Dr. Tennant Slack, who is going to train you on how to save a life that is at the point of death from opioid overdose.
I'm Tennant Slack, Clinical Chairman of the Think About It program, which is sponsored by the Medical Association of Georgia Foundation. This program seeks to reduce and prevent deaths from prescription narcotic painkillers as well as illegal narcotics. Important sponsors include the Medical Association of Georgia and the Georgia Society of Addiction Medicine. This lecture will have 2 parts. Part 1 will consist of an overview of this whole problem. We'll then look at the relatively new Georgia 9/11 medical amnesty law. We'll look at an overview of what narcotic painkillers are, and we'll look at what naloxone is. It's very important to understand the link between prescription narcotic sales and death rate. Around the year 2000, we began to see a very steep rise in deaths, overdose deaths, associated with an ongoing rise in annual numbers of prescriptions written. This rise has continued for well over a decade. Only until the last couple of years have we actually seen a drop in the number of annual prescriptions written. Unfortunately, though, we have not seen a drop in the overdose deaths to go with that. In this slide, it's a little bit of a complex slide, but if you will look at the solid line at the very top, shows that the number of deaths associated with all types of narcotics continues to rise quite dramatically. The second line is the dotted line, or the dashes, excuse me. That shows the prescription drug death rate, which also is continuing to rise, although less sharply than these two where the arrows are. And these ones I really want to point to in particular. The first of those, or the second from the bottom of those arrows, shows the rise in heroin, and as the prescription drug deaths have dropped or slowed down a little bit, I should say, heroin deaths have risen dramatically. The other arrow, the one lowest, closest to the bottom, shows a very dramatic rise in synthetic opioids, which include fentanyl, illegal versions of fentanyl, and various other versions of illegally synthesized narcotics. So now let's talk about the 9/11 medical amnesty naloxone law. This was introduced in April 2014, signed into law by Governor Deal. There are two parts to this law. The first part really applies to people who are on the scene of the overdose. The person who calls 9/11 to seek assistance has limited immunity from arrest. The second part of the law is really what is pertinent to first responders. If you are acting in good faith as a first responder and you administer naloxone intranasally, you will be immune from any sort of prosecution or lawsuit. Very important to understand that. So what are opioids? They are a group of very powerful pain-relieving drugs that originally came from the opium plant, which has been around for many thousands of years. The groups are roughly divided into those that are derived from the plant and those that are synthesized from other chemicals not in the plant. These drugs work at very specific areas in the brain, and what makes them stand out is they have a particularly deadly side effect profile. They are very potent in their ability to slow down or stop breathing. They, as you know already, induce sleepiness, maybe to the point of unresponsiveness. And also importantly, they are very potent in their ability to suppress the cough reflex, meaning that if the victim throws up, those materials may go down into the lungs, which is a big problem in and of itself. These drugs are especially dangerous when taken in combination with alcohol or other substances that depress brain function. These include the anti-anxiety pills like Xanax, muscle relaxers like Flexeril, as well as the antidepressant groups. So examples of prescription opioids are as follows. As I mentioned, there are those that are derived directly from the opium plant, and these are morphine and codeine. The second group is synthesized from chemicals that come from the opium plant, and this probably constitutes the largest and most commonly prescribed group. This includes hydrocodone, which you know as Lortab and Norco, oxycodone, which you know as Percocet, Roxycodone, OxyContin, hydromorphone, which you know as Dilaudid. You may or may not be familiar with oxymorphone, which is Opana. The third group is synthesized from chemicals not contained in the opium plant, which means that you do not have to have access to the plant to make these drugs, which is very important. The key drug in this group is fentanyl. You've heard me reference that already. I'll talk more about that in just a second. You probably are also familiar with methadone. Other drugs are buprenorphine and meperidine. So it's very important when you arrive on the scene to look for patches. There are two major prescription drugs that come in patch form. One is fentanyl. The other is a drug called Butrans, which is buprenorphine. So you want to check the body for patches. Overdose patients may have several of these patches on, for example. And I'll mention this again later. You want to be very careful if you're handling one of these patches. You want to have gloves on so it's not transmitted through your skin. I have an arrow here pointing at the mouth because some patients will attempt to swallow or chew fentanyl or Butrans patches in an attempt to ingest the drug. So we've gone through what are the prescription narcotics. Let's now talk about the illegal opioids. And by the way, the word opioid applies to this entire group of drugs that we have been discussing. They all act on the same part of the brain, and so they're all lumped into the group of drugs known as opioids. So heroin is a drug that we are all familiar with, been around for many decades as a drug of abuse. It is very, very similar to morphine. It is synthesized from morphine, and in fact, when it enters the brain, it turns into morphine. There has been a sharp trend, as you have seen, towards heroin-related overdose deaths. This drug is typically injected, and of course any drug that you inject directly into the circulation is by definition more dangerous because you are delivering it directly into the circulation. Now let's talk about the other major illegal opioid that has become particularly problematic, and that is non-prescription fentanyl and other versions of synthetic opioids. These are being made primarily outside the United States, but they are also being made inside the United States. They are synthesized from scratch using no chemicals from the opium plant, meaning the plant is not needed to make these substances. As I've already pointed out, there is a trend towards more deaths associated with these synthetic drugs. The equipment and materials needed to make these synthetic opioids are readily available online and actually not prohibitively expensive, so there are startup operations popping up in a number of places, both in the United States and in Mexico and other places. China is a big problem in terms of supplying fentanyl powder. So as I mentioned, the fentanyl is typically synthesized as a powder, and what the criminal operations do is mix the powder with heroin, or they may mix it into a prescription pill, which might in fact look just like a real prescription pill. So this makes for an exceptionally dangerous scenario because fentanyl is many, many times more potent than heroin. So when the victim ingests one of these products, without knowing it, they're ingesting something exceedingly dangerous and very, very capable of stopping their breathing. What is naloxone? This drug has been around for a number of decades. It goes by the trade name Narcan, which many of you have probably heard of Narcan. Introduced in 1971. Very, very effective at reversing overdose from an opioid. And it's very important to understand that it is a very safe drug to use in the setting in which you will be using it. That is when you are administering it through an intranasal device into the nose. Very, very safe profile. Been used all over the nation with very few complications. So how does naloxone work? How do opioids work in the brain? If you see here, the red triangle is the naloxone and the green circle is the opioid. There are special receptors in the brain which the opioids activate and achieve their effect that way. What naloxone does, it has a stronger affinity for the receptor than the actual opioid does, and it will knock off the opioid from the receptor, thereby turning off the narcotic effect. Very, very effective at doing this. So the onset of naloxone depends on the route of administration. We're going to be talking exclusively about the intranasal route, which has a wide range of onset. It can be very quick, within 2 minutes. It can be delayed based on several factors, which I won't go into here now. It's just important to understand that the effect can be very quick or it can take a few minutes. Duration of the effect, roughly 30 to 60 minutes. Understand, and this is an important note, that the narcotic that the patient, or the opioid that the patient has overdosed on, may have an effect longer than the duration of the effect of the naloxone, meaning that you may need to deliver another dose. That's something to be very much aware of. It's important to note that when you are storing naloxone, you want to try and keep it at a reasonable temperature, anywhere from 68 to 77 degrees Fahrenheit. You want to try and avoid exposure to sunlight or high temperatures. Why? Because that will accelerate degradation and reduce potency of the product going forward. If properly shelved, properly stored, the shelf life of this drug is quite long, up to 5 years. So now let's move on to part 2. We've gone through the background part. Now let's look at part 2, where we look at actually how to use naloxone in an overdose setting. So the contents of the narcotic overdose kit that we will be showing you are on the screen. Here's what the little pouch actually looks like. It contains a set of gloves in case you are handling any biological or drug-related materials that could get on your skin. Here is the intranasal delivery device, very simple. In the top corner there is a card to remind you of the steps in this process, although it's a very straightforward process. But that card is in there just in case. Okay, so how do you recognize an opioid overdose? The most obvious thing you will see is the patient is quite sleepy, difficult to wake up, perhaps even unconscious and unresponsive. The second very important point is that breathing will be slowed down and perhaps even absent. The presence of pinpoint pupils will depend on, it's very common to see in an opioid overdose, but it will depend on what other substances are involved. Other substances can reverse the pinpoint pupil effect, so don't hang your hat on pinpoint pupils. So if you see this combination of elements in the presentation, very reasonable likelihood that opioids are involved and are involved in the patient's overdose. So in this picture we see the officer quickly collecting information from the person on the scene who has called 911. Here we see the overdose patient at the bottom of the screen with pills. So the officer can reach into this pouch and take out the instruction card if need be. The officer has already put on the gloves, which is a very good idea, probably in all cases. The next step would be to assess the level of consciousness, which the officer here is doing by shouting the name of the patient. providing a sternal rub, which is a very potent stimulus to wake somebody up. The officer has moved the patient to the floor, preparing for possible other resuscitation maneuvers. All right, so if the patient is breathing fewer or less than 10 breaths per minute, it is appropriate to give naloxone. The officer is, after assessing the scene, is calling 911 for medical assistance. The officer here is opening the naloxone package to take out the intranasal delivery device. A close-up of that device is here on the screen. Note that this device is FDA approved for use in adults and children. And looks just like the picture. And basically you just put your two fingers on the top, just as in the picture, thumb on the bottom, and you just push this plunger in, and that will deliver the contents into the nose very effectively. The officer now is tilting the patient's chin back to help open the airway and allow for breathing and air to pass into the patient's lungs if in fact they are breathing. In this slide, the officer inserts the intranasal delivery device into one nostril and sprays the full contents of the device into the nostril. The officer then is checking the mouth for obstructions, and obviously if you are going to move your finger into the mouth, you do need gloves on. This is an opportunity to perform what's called a finger sweep in the mouth and remove any contents that may be obstructing the airway and preventing air from getting into the lungs. Understand that if there is no pulse, the naloxone will not circulate to the brain and not have the desired effect of reversing the narcotic overdose effect. So if you detect no pulse or a very minimal pulse, you do need to consider providing chest compressions. And of course, if the breathing rate is under 10 breaths per minute, you want to consider rescue breathing as well. Here the officer has placed the patient in the recovery position, which is helpful in terms of allowing the patient to regurgitate to the side, and it also helps keep the airway open. The officer is providing further airway assistance by lifting the chin, as you saw in a previous slide. So after the naloxone is given, as I just referenced, consider performing a finger sweep to help clear the airway if you suspect that there is something obstructing the airway. If the breathing does not increase within 2 or 3 minutes of the initial dose of naloxone, it is acceptable to repeat the dose. And it's acceptable, depending on how many doses you have available, to continue repeating every 2 to 3 minutes until respirations return and consciousness returns. Again, note that the duration of the overdose drug can outstrip the duration of the naloxone, and again, this may require further dosing of the naloxone. You want to continue to monitor the patient until help arrives to ensure they do not relapse into an overdose scenario. Understand that as the patient emerges from the overdose scenario, they can be very agitated, very combative. They may wake up in frank withdrawal, so be prepared for that. Closing thoughts. If you suspect a narcotic overdose, use naloxone. Again, it's a very simple maneuver, very safe maneuver, and has a very effective maneuver which has saved many lives in Georgia and across the nation. You want to watch for relapse and be prepared to give more naloxone if ready. Understand the wake-up can be rocky. We recommend storing the naloxone on your person in the Think About It pouch to maximize the longevity of the drug. If you do give mouth-to-mouth, we do recommend using a mouth barrier or breathing device. Here are references if you're interested. Thank you very much.